Hi, everyone. Welcome to the care during labor and delivery. Part 1. Family, right? Getting excited because we're going to meet our second patient if we can just get through this stuff. People always ask me, just last night actually, an anxious dad of a laboring woman said, "What do you think?" I said, "What do I think about what?" "When do you think she's going to deliver?" I said, "Oh, sir, if I only knew." He goes, "You'd be making a whole lot more money?" I'm like, "Absolutely." Anyways, some people want to know, like, is it going to be this week? Is it going to be next week? All of these things. And there are certain things that typically may occur prior to labor beginning, but really, if we knew, we'd be much better at stopping it when we didn't want it to happen, right? Or starting it when we did want it to happen. So it's still not an exact science. Needless to say, prior to birth, we often see that a woman experiences backache, that she has some weight loss. Lightning is not only a phenomenon in the sky, perhaps even today. It's when the fetus drops into her pelvis, engages into her pelvis, and she feels like she can breathe again because the baby's not pressing on her diaphragm anymore. That's lightning. She might have some contractions. Bloody show is this bloody, mucousy kind of discharge, vaginal discharge. And what that is basically the cervix is starting to do something. All right, it's starting to lose its integrity a little bit, and it's starting to kind of break down a little bit so that it can thin out and open up. In doing that, there's little superficial capillaries that will burst because it's such a blood engorged area. Mixes with all the other things going on up there, and it comes out of bloody mucus. That's bloody show. Some women experience an energy burst, we call nesting. That's where you see a woman who's a couple weeks within her due date, all of a sudden she feels the need to rewash, refold, and organize all the baby's clothes. Or this, unfortunately, is a time where some women decide she wants to change the whole color scheme of the nursery and gets out the gallon of paint when she perhaps shouldn't be doing all of that. All right. Unfortunately, I mean, they feel like, ooh, and they don't always recognize that it's nesting when it's happening, but that's what it is. But some people tire themselves out so much by nesting that 2 days later when they go into labor, they're like, oh, I'm so tired, I just repainted the nursery. So, anyways, that's that. GI changes. Some women just decrease appetite, some diarrhea for some, whatever. I think it's nature's way of clearing out prior to delivery or prior to labor. And we'll talk a little bit about rupture of membranes, or ROM, not range of motion, rupture of membranes. Spontaneous rupture of membranes is when the water breaks. All right, that's denoted SROM. Labor generally occurs within 24 hours. In fact, we want it to not just occur, but be completed by 24 hours afterwards. We want delivery within 24 hours of rupture of membranes. All right? It's not like the ones who have had babies or know people who have had babies. It's not like the movies where, ooh, my water broke and people are rushing off to the hospital and delivering in the driveway, anything like that. Not usually, anyways. This is one of those cases where my water broke and everyone comes from all different places and has to sit in the waiting room for 24 hours before the baby's born. Anyways, the longer the water is broken, the higher risk of infection there is. Makes sense, right? We've opened up the dam, if you will, and now there's an opportunity for bacteria to go up and kind of surround the baby. All right? So if the membranes have been ruptured for more than 24 hours, we call that prolonged rupture of membranes. Again, oftentimes we will start antibiotics, even if there's no symptoms of infection. And definitely notify the pediatrician. Sometimes the pediatrician, a more conservative pediatrician, might do blood cultures on the baby. And just to make sure that the baby didn't get infected within that prolonged period of time. What is 100% important is after a rupture of membranes, particularly if the patient is with you in the hospital, whether spontaneous rupture of membranes or if the doctor came in and artificially ruptured them, AROM, we call that, AROM, we need to check the fetal heart rate. We don't want the fetal heart rate to have any trouble, all right? So the change in atmosphere for the baby with the rupture of membranes can cause fetal distress, to say the least. I mean, sometimes with that rush of fluid comes out, so does the umbilical cord, and then we have a situation called prolapsed umbilical cord. So the quickest thing we do when woman ruptures her membranes is just check the fetal heart rate. All right, we can clean her up. We can do all of that afterwards. Check the fetal heart rate for distress. Amniotic fluid. It's generally clear or sometimes a little straw colored, a little tint of yellow to it. There is a distinct odor. It is not foul. If it's foul, then we're concerned about infection. All right, it should not smell foul. It's not like a scent I would put in a like air freshener or a candle necessarily, but it's not foul. All right. I know this. I mean, if you liked me before, great. But after what I'm about to say, I think you're going to like me even more. I recognize the smell of amniotic fluid. Huh? Don't you want me around? Yeah. It has a distinct smell. I can't describe it. Some might say musky. Some might say, I don't know what y'all saying about it. I can just recognize it. All right? So women come in, and you know what? You get this gush of fluid, a little yellow color maybe, coming out of this general area of the down belows. I have to say down belows, just because that's my favorite word. Is it urine? Is it amniotic fluid? It's a big question. A question we ask daily in my business. So a woman will come into the hospital with a soaking wet pair of underpants, or perhaps a pad that has this unsure of what it is liquid on it, right? So we have all these sophisticated tests we're going to do to confirm whether it's amniotic fluid or not. I'm going to say, yeah, I'll take that for you, and I'll put it in the bathroom. In the meantime, while I'm in the bathroom, I'll give it a little sniff. Because you know what? 9 times out of 10, I know my answer. Before anyone does any fancy tests on it, I know my answer. You probably want me at parties now, don't you? Just get on my calendar and I'll show up, okay? Anyways, there's a lot of amniotic fluid. We got 9 months worth building up, right? It can be 500 to 1,200 milliliters of amniotic fluid, all right? Sometimes it comes out in a big gush, and sometimes it's just a little trickle. It all depends on what's in the way. Like maybe there's a small gush, and then the head comes down and kind of corks it off. So there's more amniotic fluid behind the baby, but sometimes it's pretty obvious that it's amniotic fluid. Other times, not so much. A very simple, other than sniffer test, is nitrazine paper. Nitrazine paper is pH. It checks the pH of something. Anyone take chemistry or any of that? Okay. I figured. Amniotic fluid is alkaline. Amniotic fluid is alkaline. So we're going to take a little of whatever's coming out of the woman, and we're going to put a little bit on nitrazine paper, a little strip of nitrazine paper. If it turns a nice rich blue, purple color, it's amniotic fluid. Urine is not alkaline. Urine will not change the color of nitrazine paper. Regular vaginal discharge is generally not alkaline. It will not change the nitrazine paper. There are other tests that we do now too, called Amniotic. There's another test I think I'm going to talk about a little bit later, where we take the we put this mystery fluid on a Q-tip, and then we put it on a clean microscope slide, let it dry, and look at it under the microscope. If it dries in a ferning pattern, we call that positive ferning, and that's amniotic fluid. That's how amniotic fluid dries. If we're, I have seen this, and this is how you remember that little microscope thing. Some women come in with stuff coming out of their vaginas. You're not sure it's amniotic fluid or not. So we do this test. Q-tip, da-da-da. I look under the microscope, and I see little sperm. So I go back to the patient. Have you had sex recently? And her husband are like, That's what's coming out of your vagina. Have a nice night. It's embarrassing. Generally now, I ask. We still have to rule it out, but I'll ask, when was the last time you had sex? They're like, about 45 minutes ago? It's probably what it is. We're just going to run some tests. Yeah. Sorry, I am completely inappropriate, but have you come to expect that? Anyways, let's talk about the P's, all right? We have some critical factors in labor, and I think ATI likes to cleverly put things together. So we're going to put them all with P's. The pelvis, or the passage. The passenger. The relationship between the passenger and the passage. The primary powers, the forces of labor, pushing and contraction. And the psychosocial considerations. Let's go through each one. The passage is literally the way out for a vaginal delivery, all right? There are factors. Maybe the kid is too big to fit out, all right? That's a pretty important, thing we need to kind of match up. We want the kid to be able to fit out of the bony pelvis. All right, so we'll talk more about that. The passenger, the fetus, all right? Maybe the fetus is not presenting into the pelvis the way we want it to, all right? Maybe that fetus is just too big, it won't fit, all right? Maybe it's butt down or arm down or, not head down the way we want it. Or maybe the head is turned, head down, but turned in a way that it doesn't line up with the pelvis the way we want it, all right? We'll talk more about those. The forces, or the powers of labor are contractions. And then as labor progresses, the pushing, all right? They need to be adequate to finish the job. And finally, psychological considerations. Fear. I have seen women let fear interrupt their labor. If you tell them that's what it is, they will deny it, I'm sure. But I have seen women afraid, so afraid that it actually stops stops their labor. Yeah. So fear cannot be discounted at all. All right, passage. There is the pelvis. That opening there, that big hole there, needs to be bigger than the